I want to first recognize President Eberline, obviously President of the American Surgical. I also want to recognize Dr. Bismuth and thank him for his leadership in having this, I think, historic union between the French and American surgical academies. I also want to recognize the distinguished members of the Academy and my distinguished colleagues who traveled with me from America to come here. You know, I have two regrets, and I'll just tell you up front. I regret that I don't speak French fluently, and I regret that this is my first visit, official visit, to the National Academy. I can see why Thomas Jefferson fell in love with the academic village of Paris in France. Let me just start. I've been given the very tough task, maybe because I was president of the American College of Surgeons, the very tough task of opening Pandora's box. They assigned me to talk about the challenges facing not just American surgery, but global surgery. So let me start. Let's see now.
The middle button. The middle button.
The middle button, okay, good. Thank you. I would like to focus on healthcare system. Now, I'm not an expert on healthcare system in France or Australia, but I would like to talk more about the global challenges, but I'm going to concentrate on my country. And I'm going to talk about the major challenges that you see on this slide: globalization of the economy, the role of government in healthcare, the rapid changes in technology, the aging population. All these are challenges, because all these will, if not done correctly and not monitored and not addressed, will end up with, as you can see, the last one, healthcare disparities, or suboptimal healthcare. Well, one of the major influences with any sort of industry, particularly the healthcare industry, has been the global economic recession that we are experiencing throughout the world. I'm going to use this because this is. You can talk about threats, and here are the threats that you have facing any nation, but the one that I would like to emphasize would be healthcare disparities. When I was 4 years old, the greatest healthcare risk, now you know my age, was acquired heart disease. In 2011, as will be the case in 2012, 2013, 2014, at least in our country, the greatest healthcare risk is lack of access. So that's one of the great disparities. And in all fairness, you know, the 20th century had the civil rights sort of era in America. The 21st century will have, the civil rights era will be healthcare disparities. So in all fairness, it will be very tough for me to present what I was assigned to do about challenges in healthcare and not talk about some sort of healthcare reform. Now, having said that, we have a reform, the first one, the only president that was able to really get through a healthcare reform. In all fairness, there's a disconnect. I'm not going to get political today, but he was the first to accomplish this. And in all fairness, the American College of Surgeons, we actually opposed it. We did support the original House of Representatives version, but when it went to the Senate, my colleagues, obviously Dr. Fisher was one of my colleagues, and other members of the college, we decided that we just could not support it because it did not address some of the things like the sustainable growth rate. There was no real major sort of accent on medical liability. So we actually opposed the reform. But it has passed, and we will accept this. It's a challenge for us, but we will accept it. It's a law now, and we're supporting it. But having said that, if you look at this slide, there's several things that still have not been resolved, even with this health reform. We still have a rising healthcare costs. We still will have about a 50 million citizens uninsured. We will still have major physician shortages, and the disparities in healthcare, at least in our country, will still be very substantial. So in all fairness, I think the consensus, maybe not in France, because I'm not an expert here. This is just my third or fourth visit. But globally, for the most part, the healthcare systems globally are broken. And the controversy is, how do you fix it? That's the great challenge that we face. Now, I don't like to ever give a talk and not have, it's easy to throw a hand grenade in a crowd. It's difficult to come up with solutions. So what I would like to do is have a global perspective and talk about some of the potential solutions to most healthcare issues in most of the countries, certainly in the United States. But I'm going to have a proviso. This is unofficial. I'm taking my hat off as the president-elect of the American Surgical, because I'm not speaking for the American Surgical. I'm not speaking for the college. I'm not speaking for the board. But if you had to have a healthcare reform to address the challenges facing healthcare in the United States and other countries, then I won't speak for France, you're going to have what you see on this slide. You're going to have the enhancement of the healthcare workforce. You're going to have to reduce the inappropriate expenditure. You're going to have to promote proven healthcare initiatives, proven, evidence-based. You have to have some sort of accent on medical liability reform. And again, I know some people disagree with this, but at the end of the day, I can speak for the United States. We can't be the wealthiest nation of all time and not have some form of universal coverage. And last but not least, we have to have, obviously, technology that interfaces and communicates with other technologies as far as healthcare-related issues. So let me quickly go through that. There are two fundamental variables that affect your health status. I don't care if you can be in France, you can be in Jerusalem, and you can be in Spain. Quality and access. In all fairness, in our country, although people are beginning to say that our quality has gone down, that's not the case. There's no evidence to support that. What has been affected has been access. We have 315 million people in the United States. 50 million are totally uninsured. I don't care what metric you use, they're uninsured. Another 40 or 50 million are underinsured. So a third of the population is suboptimally insured. So we have an access problem. And so we have to obviously emphasize workforce. George Sheldon and my good friend who's in the audience, I'm glad he did decide to come, really highlighted this well. And I'm going to talk about general surgery. There has been a precipitous decline in general surgery. And we have not been, obviously, we don't have a robust pipeline. So this is a problem that's going to continue for a while. The shortages have been well documented in our lay press. And this is why it's important. And I think Dr. Trunke highlighted this in one of his talks. We have 3,000 counties, a little bit more than 3,000 counties in the United States. Okay. 1,100 counties, as you see here, more than 1,100, are without one general surgeon. Now, if you accept the premise that you cannot take care of emergency surgical problems unless you have a general surgeon, because really there's no substitute for a general surgeon. We have substitutes for family medicine. Don't tell my wife I said that. She's a family medicine doctor. Make sure you don't tell her I said that. But there's something, you have nurse practitioners and all the like, but you cannot substitute for the general surgeon. So when you have a county that doesn't have a general surgeon, you have an access problem, particularly with emergency surgical care. And this is what I'm talking about. I'm talking about the perforated appendix, all the emergency care. I know we have some general surgeons who don't necessarily practice general surgery, but if you don't have a true general surgeon in a hospital, you have access problems as far as some of these issues you see highlighted on this slide. And let me make it even more problematic. If you add another 358 counties, you have about half of all the counties in the United States have less than the lowest recommended standard for access to a general surgeon. Now that is a challenge. And this is something that has been highlighted by my colleagues. When you don't have a surgeon, let's say you lose a surgeon in a rural hospital. Most people think all the hospitals in the United States are 500, 600, 700 beds. Most hospitals in the United States are 150, 100 beds or less. So if you lose a surgeon in a rural hospital, there's a good chance that hospital will close. And if that hospital closes, it's a major negative impact on their economy for that community. And plus, at the end of the day, the reason why this is such a challenge, maybe not globally, but certainly in our country, it takes 15 years to put a surgeon on the ground. With training, residency, and all the like, it takes 15 years. Now, I've stated this before. We all talk about quality, and we have two of the premier organizations, the French Academy, National Academy, American Surgical. We are just engulfed with quality. But if you don't have access, you don't have quality. In aggregate, if you don't have access, you don't have quality. And so in all fairness, the college has two core values, and I think the core values that we all share: quality surgical care and patient safety. During my presidency, I tried to emphasize that we needed a third one, and that third one should be optimal access. Now, let me quickly go through it because I'm not going to run over my time. Our healthcare expenditures have been documented to be unsustainable. This is a slide, as you can see here, by 2020, we will be spending close to 30 cents on a dollar for healthcare. Now, a lot of people, and even if you do per capita, this is an unsustainable trajectory. Why is that the case? Well, a lot of people say, don't worry about it. Market forces, we got some business people, minds in this audience, but even they will tell you if they look at it. Market forces have never had an impact on healthcare expenditures. Let me say it again. If you're depending on market forces to curtail healthcare expenditures, that's not going to happen. Because you only have $1. If we're spending 30 cents and another few years after that, it'll be 40 cents, we have to still pay for education. We still have to pay for art. And I don't have to say that how important that is being in France and Paris. Research, we will not be able to do that. And so in all fairness, quality care is cost-effective care. I mean, we have to do something. We're trying to find some way to curtail the expenditure. Now, let me talk about proven healthcare. We have a lot of bells and whistles in the United States. In fact, I was in Philadelphia the other day, and there were within almost a rock throw, there was an institution I could hit, and there would be a major liver center of excellence. And then another few blocks, there was another center. And then one hospital had 2 robotic machines, another one had 2. And so at some point, I like to call that the unrestricted medical arms race. I'm not sure we can afford that. I'm not sure we should consider some form of regionalization. Because unlike any other industry, this is what is so unique. You know, in technology, non-medical technology, if something became advanced technology, let's say this computer. If I purchased this computer 20 years ago, it would be $3,800, $4,200. Now I can go to Kmart, not that I get my computers from Kmart, and get a computer for a couple $100. In healthcare only industry where more advanced technology is more expensive. That's something that we need to find some way to address. There's no other industry where more advanced technology does not ultimately become cheaper, besides for healthcare. And there's a ruse. Now, I can't speak for France, but there's a ruse in our country and other countries. There's too many unproven procedures. There's overpriced drugs and devices. If you don't believe that, look at your hospital bill, if you're in the United States. Unbelievable, overwhelming administrative costs. Dr. Trunky highlighted this before, and others, Ted Copeland. In fact, I'll just tell you about my region. I come from Norfolk, Virginia, the world's largest naval installation. We have a 5-hospital consortium. Now it's going to be 6 or 7 in another year. Our CEO for 5, I'm not talking about a CEO for General Motors or General Electric. The CEO for that 5 or 6 hospital consortium makes $6.5 million a year. And next year, he's supposed to make $10.2 million. That's what I call overwhelming administrative overhead. So when people say, you know, the doctors need to ratchet down, yes, that's a challenge for us, but I'm not sure that's where all the money is going. And then obviously we have to talk about the fact that we squander $1 out of every $3 documented for unproven. All I have to do is show this slide. I don't have to say anything. This will be a silent slide. The number of CAT scans that we're doing, I just had a patient the other day that came in, a young man, McBurney's tenderness, diaphoretic, white count elevated, and they still got a CAT scan. And so at some point we have to find some way. Now I'm not talking about rationing. I'm just talking about being a steward of the expenditures. Now one thing I don't like to talk about, and I can't say what's going on in France and Greece and other places, because there's challenges everywhere. We have a challenge with Medicare fraud. We have $80 billion documented in fraud, and I'm glad that I don't see anybody here from New York. New York alone has $20 billion in fraud alone. So we can talk about quality, and that's fine. But at the end of the day, one of the things we have to consider is comparative effectiveness, so that we are very effective and efficient and cost-oriented with what we do. Translation number 1, you test about which care actually works. Then as you go further up the pyramid, you test who benefits from this promising innovation or technology. And then can it be applied to all groups? That's where we should be emphasizing. And then I think we'll find out that we'll have a more efficient and cost-effective system. Medical liability. I don't know about in France, but we have our public is frightened. They're not frightened if they go to UCLA because they know they're going to get the best care, and we have some great experts there. But across the country, they're frightened. They go to the lay public to find out where's the best doctor, where's the best hospital. So you can see why they would be sensitized as far as suits. Plus, they know our history. They don't have the same trust in the healthcare provider, and you can see why. They've read this before. This is a very famous study. Some people question the data, but let's say you question the data. Let's say you don't believe it's 98,000 deaths based on mistakes. Let's say you just said, well, it's probably 44,000. Let me tell you what that means. 44,000 deaths based on mistakes. This is from the Institute of Medicine. This is a great book if you ever want to read a book on being wrong and the impact by Schultz. 44,000 deaths based on mistakes is like having a 747 jet packed. I came here on a 747 jet, and it crashes every 3 days. That's 44,000 deaths a year. Now you can imagine that happened. You got to be kidding. People would be outraged. They would never fly. They'd all be like Aretha Franklin riding on a bus to go places. But that's what we have reportedly in our healthcare system with mistakes. Now, universal coverage. I don't know about the growth trajectory in France, but in our country, we increase our population by 25 million every decade. So we have a robust population that's going to get even more robust, and it's going to age. The good news is that we're aging, that we are living longer, but what happens with that, as we all know, is that we end up having more comorbidities. And it takes twice, if not 3 times, the time and effort to take care of somebody who's elderly. What we are talking about is challenge to the best healthcare system. The best healthcare system is represented here with this bell-shaped curve. But we don't have a bell-shaped curve. The challenge we have is changing our curve, which is really skewed to the right. We have under that, everyone in this room is probably under that curve here, to the right. But to the left, you have suboptimal healthcare. If you look at a stool, you talk about patient care, you have 3 pillars that will keep that stool upright. Quality, which we have. Safety, which you can question with the 44,000, 98,000 deaths based on mistakes. But the main problem we have is access. And this access gets worse. That's why I always look at the unemployment figure. I was recently in Detroit. Unemployment there in some areas of 20%. For every percentage increase in unemployment, I don't know about in France and other countries, you add another million people to the uninsured list. Now let me talk about this and I'll end on time. We cannot talk about having the best system in any country if we don't talk about information technology. When you talk about the major forces, whether you're in Paris or Cairo, you talk about 4 basic influences: expanding knowledge base, IT, information technology, chronic care needs, and payment policies. Well, where we have not done well is information technology. Last century, it was reported that scientific knowledge, and we heard a lot in the first 2 talks, and we heard a lot from Dr. Busatil soon, doubled every decade last century. It's supposed to triple every decade this century. You cannot, even the bright minds I see in this room, you cannot process that and implement it without some sort of IT system. And here's where we are. That's why I always have to smile when people talk about 6 Sigma. 6 Sigma is something that everyone wants to apply to medicine, but we cannot even touch 6 Sigma. 6 Sigma means that out of 1 million transactions, you have at least less than 4 mistakes or defects. Well, how can you do that if you're making 2 mistakes or 1.7 mistakes per patient per ICU, 44,000 deaths to 98,000 based on mistakes? We can't approach that without IT. Because if you look at IT, these are all the things that true information technology can address. And particularly the ones that I highlight here. The distribution of information for those who obviously are not having optimal access, quality improvement, all the things you see on this slide. And this is just one component of IT. This is what's so embarrassing. You look at electronic medical record usage across the world, you see Sweden, Netherlands, Denmark, and the United States is here. And then if I show you another slide, you can see where France is. You're not going to be able to address all of the expansion of technology and information without an IT system. And an IT system that can interface with other IT systems. Now, let me just stop here because I know I'm going to pass my time. The great challenge that we have in many countries, and I just will speak for the United States, is that we have a paradox. We have a lot of money in the system, but what's happening is that we have a diminishing returns. We have worse access, suboptimal preventive care, more mistakes. So I have come to the conclusion, now I'm not speaking for the college, I'm not speaking for the American Surgery, I've come to the conclusion that this is one of the few problems that more money will not solve. We can pour in fact, I have a slide showing you, this is the projection. By 2018, we will have $4.35 trillion as far as healthcare expenditures. It's not the money. We need some sort of prioritization, better leadership, better stewardship, because I'm going to end with this slide. If you look at where we should be, at least in the United States, we should have a life expectancy based on the money that we spend of over 80, almost 82 years. We're about 5 years, half a decade off that, because obviously we're not doing it the right way. So more money will not solve this problem. I wish I had 2 hours to talk to you, but they only gave me 10 or 15 minutes. But I'll be more than happy to take any questions. Thank you very much for inviting me.
Thank you. Dr. Britt, thank you a lot for this superb talk. I may say that the problem you expose, we have, I may say, in part, in majority, we have the same here, except one.
Okay.
The one is that since 1945,
Here.
okay, with General de Gaulle, when he became, after Second War, he became president of the French Republic, one of the first things he said was to establish the social security system. That means that, and even today, all French, rich or poor, even the poorest, even those who have no house to live, all of them have the same right to be cured. They may go to the hospital. They have nothing in the pocket. They need something. They receive it. The same. If you are rich, if you are poor, exactly the same. You know, I speak about liver transplantation. You have no resources. You have nothing. You go and you need a liver transplantation. You will have the same right that everybody when you are on the waiting list. If you have a king from outside, you have no king. From outside, with luggage full of money, you can do nothing. You will not have any privilege in front of the poorest of the French national. It will be before you.
Yeah.
And nothing will change that.
That's one of the advantages.
That's
one of the advantages of having a global alliance, because there's some things we can learn.
And we must fight to keep that. It is not easy, but I think, if you agree, that not only we accept this system, but we want to continue, even if it is a lot of money, a part of your salary is going to the social security, no matter. Even if you don't use it personally, but as you said, we are growing more and more, we are becoming more and more age, and we will need this later on. And the young will pay for us, as today we pay for them. So this is equality.
Yeah,
You agree for that?
I'm glad you brought that up, because I meant what I said. We have money in our system to take care of this. We have money in the system. This will not require another dollar if we did it the right way. Well, thank you all very much, and I'll be around, so feel free. Yes, sir.
Yeah, take the microphone, please.
And again, they asked me to give a controversial talk. I want to let you know that I'm not controversial. The issues are controversial. And so feel free to ask me anything you want.
Nice presentation, sir, and we share probably most of the data you presented in France, except for the access.
Okay.
But I think that you presented a very pessimistic image of what we are facing. And my question is, what happens with the patients who are not insured in the States concerning surgery?
I tell you what happens. That patient's access is through the emergency department. And often they come in when the disease is more advanced. So they have a high morbidity, high mortality, and sometimes they come in too late. So yes, we have, a lot of people say, oh, we have universal coverage because they can come to the emergency department. But those patients don't come in a timely manner. By the time they come in, oftentimes it's advanced, and obviously the outcome would correspond with the fact that it's advanced.
But, you know, even if we don't have the solution, unless we know the problem, and the first thing is to know the problem, and you expose perfectly well all the problem that you have, that we have to, the vast majority of what you said, of course, we encounter that about all the, you know, the mistake by surgery, all the, you know, we pay a lot of money for useless thing, the same that you.
My only regret in my talk, there was 2 issues I wanted to bring up, but I knew it would take 2.5 hours to discuss. One is the potential cut in the graduate medical education funding for us, which means that I think that's going to happen. I think it's going to be 30 to 50%. That will be devastating. That will change the whole landscape. I'm talking about I don't know about what they do here, but I obviously have funding for residents, for most residents. Right now, it's on the docket now. I just heard 2 days ago that in the bill, they're thinking about taking $9 billion out of GME. That's a 30 to 40% cut. That's what I wanted to talk about, but I didn't have the time. And what else I wanted to talk about was workout restrictions. And we could talk days and weeks on that. But I left those 2 challenges out, not to ignore them, but I knew it would take too much time. Dr. Fisher?
Yes.
Well, that was a very cogent and complete review of all our problems. There are 2 more that are coming down the road that you have not mentioned, and one is the fact that in our country, industry pays for a lot of the health care in one way or another. This started in 1946. People have employment health insurance, employment-related health insurance. Next 5 years, 50 million people are about to lose their employment-related health insurance. Point number 1. Point number 2, what I hear down in Washington is that the SGR, the doc fix as they call it, is not going to be fixed next year. And there will be a 20% cut in reimbursement for surgeons over the next 3 years, only part of which will be redistributed to family medicine, primary care. So what we have is we have a situation in which we will not have enough physicians.
That's right.
And I don't care what they do with it. You don't need GME. Nobody's going to be a doctor.
For those who don't know, Dr. Fisher probably is one of the most knowledgeable people on the healthcare issues facing our country. So I want to recognize him for that.
Sorry, Ali, I think that you have to stop, but we have 3 days to speak. As you said, you need hours and hours. This is a very important topic for all of us. But sorry, but
I'll try to brush up on my French in these 3 days. Thank you very much.
Thank you. We thank you a lot.